Just because you don't have sneezing, watery eyes, runny nose, those types of classic allergy symptoms does not mean you do not have allergy. Simply having nasal congestion, facial pressure, facial pain, headache, those types of symptoms alone can still indicate that you have allergy. So if you go to your doctor's office and your doctor says, look, we've got to rule out allergy, let the doctor rule out allergy.
Hey everyone, this is episode 4 of Vital Discourse with Dr. Ben and Dr. Lee. Today we're going to talk about chronic sinusitis and allergy, how to tell the difference between the two, and what are the standards for diagnosis and treatment.
Okay, thanks, Ben. Once again, a great introduction to the topic. So, when we're talking about chronic sinusitis, which a lot of people don't even kind of understand the concept of chronic sinusitis out there. They know, well, I went to my doctor said I have sinusitis. Most of the time, if it's not an ear, nose, and throat doctor, they're just telling them, you've got sinusitis. Many times the doctor doesn't even know the difference between chronic sinusitis, acute sinusitis, allergy. We know that allergy and sinusitis have some symptoms that overlap each other. So, Ben, why don't we start with first discussing allergy, since that is the thing that people get bombarded with the most, and let's discuss how do we know we have allergy versus anything else, versus even a common cold or that type of thing. And then once we go through that, then we can talk a little about chronic sinusitis and how to tell the difference between the two.
I'm a big fan of the 30,000-foot view here. I mean, the nose has certain ways to behave. When the nose is bothered, there are telltale signs, and those are the same across all fields. So you get stuffy, you have drainage, you have pressure, and you have a postnasal drip. Those are very common things. You add to that the paranasal symptoms of headaches and things like that, and everybody's been there. Look, stuffy nights are bad nights. Everyone knows that. If I were to go home and tape my nose shut tonight, I'd have a terrible night's sleep.
And you'd
also
have sleep apnea,
trying to get
right?
through.
We learned that in
Yeah,
the previous
exactly.
episode.
You'd have immediate sleep apnea. So everybody's been through this. Everybody understands in general what a bad nose looks like. What causes the bad nose? That's the whole point. When you and I started in medicine, the physical diagnosis aspect of this was huge and also error prone. Remember, we were taught to percuss the sinuses, listen, and you tap the forehead. We didn't have CT scans that were readily available back in 92, 93. With the availability of all this data, scoping with fiber optic scopes, you can look deep inside the nose, CT scans that you can readily get in your office in 5 minutes. It behooves you to figure out in an algorithm what the heck's going on. If allergies, non-allergic rhinitis, acute sinusitis, chronic sinusitis, if they can all have very similar looks in terms of your symptoms from the nose, how do you figure out what it is? And is it even important to? I mean, it's important to because we treat them differently. So you got to have an algorithm. As when you're a doc seeing somebody for their nose and they come in, you have to have this algorithm where you sort of ask general questions and then get data. I don't have a tricorder. I can't do Reiki. I can't put my hands over you and divine that it's allergy. And I can't accurately physically diagnose you, really. I can ask questions and try to discern it, if there's a seasonality to it, if it's associated with certain exposures. But in general, I want to ask myself some questions and answer it with data. For me, I use a CT scan and a scope in my office. And Dr. Lee, what are your methods of choice when you're trying to answer these questions? Is it allergic rhinitis, non-allergic rhinitis, or chronic sinusitis?
So I guess the answer to that first is to kind of explain to our audience what the difference is between the two. So if we focus first on allergy, what is allergy? So allergy is a response by our immune system against things that the immune system determines are foreign. Okay. Now, how does the body know the difference between something foreign being something like dust or cat dander versus something being foreign like a virus or a bacteria? Well,
pollution. There are certain things,
right?
or a small molecule of pollution.
So the allergic arm of the immune system produces a special antibody called IgE. And IgE is an antibody that has a predilection for certain types of proteins that we get exposed to. Infectious substances like viruses, bacteria, fungal, let's just say viruses and bacteria, it generally does not react to. Fungus particles, it can, because you can be allergic to fungus or mold. Certainly, we all know dust, trees, weeds, grasses, danders, things like that.
Those are called environmental, right?
Right, environmental allergies, although obviously we can have allergies that are not environmental, right? We can have food allergies. We can go do a whole subset.
But for the nose, yeah.
Right.
For the nose, it's things you breathe in.
Right, on food allergies and allergies that to things that touch our skin, contact allergies, and those types of things. But these environmental allergies, this antibody, it binds to it, and it causes something called an allergic cascade. Basically, all these different substances get released in our system, and they go to our end organs, our nose, our skin, our lungs, and they cause changes. Most of those changes end up being inflammatory or stimulatory. Inflammatory means things swell. Stimulatory means something's produced, like excess mucus or something of that nature. So we're usually talking about, when we're talking about allergy or allergic rhinitis, allergy in the nose, right? Allergic inflammation of the lining of the nose. We're usually talking about sneezing, watery, itchy eyes, runny nose, dripping in the back of the throat or post-nasal drip, nasal congestion. Now that we've decided that, okay, we have someone that comes in with those symptoms, what if that person adds on a symptom like, I've got some dental pain, my upper teeth hurt, or I've got a headache, or I've got pressure in my face? Well, now...
Or pressure in the ears.
Or pressure in the ears. Now we're saying, hey, you know what? Could that all be allergy? The answer is possibly. Could there be something else amiss? Yes, we could be now going over into chronic sinusitis. So what's the difference? How does one interact with the other? How does one affect the other? So the first thing is, if we're dealing with something like allergy, and most of the time this is what your primary care physician is going to do. They're going to assume when you come in with these symptoms, either you got a cold or you have allergies. How do we know if there's a difference between a cold and allergies? Usually the amount of time you've had it, right? So if it just comes up, out of nowhere, you're symptomatic for a couple of weeks and it goes away, that was probably a cold, right? It's probably a viral upper respiratory infection. If it's something that continues or it's episodic, depending on your exposures, your environmental exposures, or time of year, that type of thing, it's more likely going to be allergic. Okay.
Or if you get over it, if you suddenly have those symptoms and you get over it in a day, and that happens 2 or 3 times during a 2-week period, again, that's probably an exposure. You're exposed to something, because the time course for your body to recognize, fight, and get over a viral or bacterial illness is about 2 weeks or so.
Right. So when we're looking at then, and to answer your question, because my answer is so long-winded, to actually answer your question, how do I evaluate these patients? Well, obviously, first of all, I ask questions, right? I need some history to see what's going on. Once I've gotten that history, I want to look. So I want to look in their nose. I look in their nose. I usually use an endoscope, which is something that we as rhinologists use, rigid telescope to look in their nose. What does that tell me? It can tell me things like, does it look swollen? Are there obstructive things going on in their nose, deviated nasal septum and that type of thing? Are there polyps, which are actually a type of chronic sinusitis, an allergic chronic sinusitis? Yeah, the overlap between allergy and chronic sinusitis, right? They're not mutually exclusive, okay? And so that's your initially how you look at things. CT scan. CT scan gives us a great differential as to whether or not we've kind of gone over the line into chronic sinusitis. Not to say that a CT scan that looks relatively normal to a radiologist, that we as rhinologists and sinus specialists don't see something that would indicate that there is chronic sinusitis along a continuum, but it's just not significant enough at this point to really show a lot on a CT scan, but that does give us a lot of information. Next thing is an allergy test. So skin testing, people have heard of that, I'm sure. But small amounts of what you might be allergic to with a needle in your skin, don't worry, it doesn't hurt. It's like a mosquito bite. It's nothing, okay? But you do that and you see, are you reacting to it? If that shows that it's positive, then allergy may, not always, but may be a major part of what your symptoms are, and then you can get.
So what I'm hearing in your algorithm then is the person comes in, you talk to them, you look at them, you get a CT scan. It tells us whether or not there's disease mostly in the sinuses or mostly in the nose or both, and then if it's in the sinuses, you're probably going to wind up treating for chronic sinusitis, or depending on the length of the symptoms, and then to determine whether or not it's allergic rhinitis or non-allergic rhinitis, you're going to do a test, some sort of a patch test to actually see, because there's different treatments for all those things. Yeah,
generally speaking, you're 100% right, and I think that an important part of at least the way I treat this is I use medical therapy somewhat diagnostically. Right. So when I'm looking in a nose, and we're talking a lot about the nose here because that's kind of our such a big area of specialty for us, but allergy obviously can affect the whole body. When we're treating with certain types of medications, that response to that medication gives us a lot of information as to what might be the cause, number one. Number two, is it reversible? Number three, are there structural issues at play here that also need to be dealt with and to figure out what's going on? But to your point, many times we'll be looking at, well, I want to rule in or rule out allergy. And, for example, our CT scan shows evidence of narrow openings of the sinuses, thickening of the lining of the sinuses, fluid levels in the sinuses. And now oh my goodness, we're now in a potential sinusitis picture here. But Ben, tell us, what is chronic sinusitis? Is there a definition of chronic sinusitis? And we, as people that actually see and treat patients, do we need to follow that specific definition? Or can you see a patient without it absolutely following that definition and say to yourself, I actually think we're probably dealing with chronic sinusitis here?
Yeah, I mean, so there's actually a definition of chronic sinusitis, and that gets updated and tweaked by the American Academy. Actually, a committee that you and I are both on now. Thanks for joining us on that. There's a paranasal sinus committee in the American Academy of Otolaryngology that I've been a member of for 6 years. Dr. Lee has just joined me on that panel. He's going to add fantastically to it. But they periodically, we revisit the diagnosis pattern. What goes into making it a formal diagnosis of chronic sinusitis versus acute sinusitis? Basically, there are, I don't want to get too technical, but there are criteria that you draw from in order to determine whether or not it meets the definition of sinusitis in general, and chronic just makes it so that it's more than 12 weeks. So if you've been struggling with these types of problems for more than a 12-week period, you typically start to look at it as a chronic issue. But when I see a CT scan, I can also sort of determine if there's air fluid levels in there, and I see, and I have a person telling me that they haven't felt good and it just came on 2 weeks ago, it's probably an acute sinus problem. If it's a thickening of the lining or narrowed airways, narrowed openings to those sinuses, bony thickening, things like that, and the person's been saying, this happens on and off 3-4 times a year, and I always feel kind of like a little bit, face pressure and whatnot, it's probably a chronic condition. So the 12-week mark is hard and fast in terms of the American Academy's definitions. But chronic sinusitis is a global picture that I get when I'm talking to somebody and looking at their CT scan in my clinic.
So I guess a good thing here to do is to go back and say, well, our initial question was, how do you know if it's allergy versus chronic sinusitis? And the answer is, you don't always know, do you? Right?
No, and quite often they're occurring in the same time in the same patient. So I take care of things that need to be taken care of on a logical basis, that 30,000 foot view. So folks coming in have to remember, we both do allergy. And if I'm what's the treatment for allergy? Well, you can give meds, but allergy has some treatments that take years to do. Immunotherapy, either drops or shots, is typically a 3 to 5 year course. I'm not going to get someone started on that if they have a problem that's more acute than that. By more acute, I mean chronic and acute sinusitis. You have a bacterial problem with drainage patterns and possibly structural problems in the nose. Those two things can happen simultaneously. You get cyclical swelling from allergy, and it can cause chronic sinusitis in a person with a badly deviated septum. Those little airways, those little openings get swollen shut. The patient's sinuses fill with fluid, and they get thickening and biofilms and whatnot. So quite often they're happening in the same patient, and they both need to be addressed. Certainly I don't want to step off on a 5-year course of allergy drops or shots in somebody who has a sinus problem that hasn't been addressed, or a structural problem that hasn't been addressed. And people do that all the time. They go into an allergy office or a family practice that does allergy, and they never do a CT scan on them. They never do a scope on them. They don't look inside the nose. They do have some symptoms of allergy, and so they start treating that allergy. The problem is, Dr. Lee, in the way we treat the allergy. It's a very nuanced, subtle thing, immunotherapy, and it requires that you don't have a cacophony of signals being given off by a current infection in order to work. You've got to give a little message every day or every few days to the immune system to calm it down. Because allergy, we all know, is basically you're reacting to the world. You're misidentifying innocuous things, grasses and trees and pollens and dust, and you're misidentifying as though it's a pathogen coming to hurt you, and you respond to it. The symptoms you get, the typical hay fever, was that they noticed, way back in the day, hundreds of years ago, fevers were terrifying, and you'd go out and you'd get kind of sick, and they'd be like, oh my, you're in the barn, you're sick, and then you come away from the barn and you're like, oh, I guess I'm not sick. And then you go back to the barn and you're sick, and then you come back and you're not sick. So they noticed these things in allergy, and when you're trying to treat it, you're trying to whisper to the immune system to tell it to switch from a Th2 to a Th1 pathway. We can get into that later. But you're trying to switch gears and stop it from misidentifying things, right? And so you can't do that if you have a current infection inside your sinus that is giving off all kinds of crazy messages. It gets lost in the cacophony.
Yeah, that's completely accurate and a great way of describing it. Basically, what you're doing with allergy immunotherapy, and people hear about allergy immunotherapy, but they're never really explained, why am I doing it and why does it work? Well, why are you doing it? Well, obviously to treat the allergy. Why does it work? So you're giving me what I'm allergic to. How is that helping me? Right? Well, it's helping you because we've identified by our testing the exact concentration that will stimulate your allergy. And we're giving you a little less, right? We're giving you a little less so it doesn't stimulate your allergy. But the non-allergic arm of your immune system, the part of your immune system that treats or fights off viruses and bacteria and infections, it recognizes it as being foreign. And it's a lot more sensitive than the allergic arm of your immune system. So it identifies it, and it starts building up IgG, which is this blocking antibody that goes ahead and gloms onto or connects to that antigen, that dust particle, that cat particle that gets into your body, and removes it from your body, but without symptoms. And that's the key, right? So when we fight off an infection, we're fighting off infections every single day. We're fighting off infections. We're fighting off cancers every single day, and we don't feel it. That's what the non-allergic arm of your immune system does. The allergic arm of your immune system always give symptoms. So converting it to your body looking at it and saying this is the same as if it's a virus or a bacteria, as opposed to treating it as if it's dust or mold or trees or weeds or grasses, that's what immunotherapy does. And it takes time to do it. Doesn't mean that it takes forever for you to get improvement in symptoms. Most people will get improvement in symptoms by 3 to 4 months afterwards. But if you don't keep it up for that 3 to 5 years, as soon as you stop, it's going to go back to the way it was. And that's the important thing to discuss with patients.
Yeah, but an important thing to reiterate, though, is if you try to do immunotherapy in the presence of an undiagnosed chronic sinus disease, a bacterial sinus problem, biofilm, chronic inflammation in the sinuses, you're going to have an uphill battle, and it might not work. It'll prolong your use of those drops or shots without as much of an effect.
And I think that people don't realize the complexity of this, right?
No,
people just don't understand, why is this so complex? Why can't you just give me something and make it go away? Well, it's not that easy. It really isn't that easy. I mean, you many times I'll have someone come into the office, and based on their symptoms, which are going over into the chronic sinusitis realm, I'm getting facial pressure, I'm getting dental pain, I'm getting headaches. And their scan, it's really not showing a whole lot of chronic sinusitis, but their symptoms are sure consistent with it. And I see structural issues there that may be at the root of it. And I treat them as if they have chronic sinusitis. And they're wondering why I'm putting them on antibiotics, even though I don't think they necessarily have an active infection. Explain that to me.
Yeah, I mean, look, a lot of times the infection doesn't show up in the CT scan. CT scans were never even a part of the main diagnosis core from the American Academy for decades. It only came in just shortly after, in the early 2000s, about 2004 or 2003, as an adjunct. The CT scan always undercalls what you see, which is why quite often I'll go in and take a look if I see telltale signs like bony thickening and narrowing, but I only see a very, very tiny amount of change on the CT scan, I'm going in with a scope, a fiber optic scope, not just looking from the front of those. I'm going in and looking around at the actual openings and trying to see some telltale signs there as well. Quite often you find actual evidence of chronic sinusitis on the scope where the CT showed very little. So the consensus from our academy is that it's a clinical diagnosis with a scope and or CT in general. It's not hard and fast. The CT scan is not the end all be all. It helps us quite a bit, but by the time you've already got a tiny little bit of thickening on the CT scan, when you look inside of there, you can see gross evidence of drainage and chronic sinusitis. So very important to make that distinction.
Yeah, I think that's just a very, very important point. I'll say the way that I discuss it a lot of times with patients when we're dealing with really these 3 different concepts: the concept of allergy, the concept of chronic sinusitis or chronic inflammation in the lining of the sinuses, and the concept of structural issues that are maybe at play that are making both of them or one of them worse, is I point to the door of the exam room. And I say, if that door is open 6 inches and I need to get through it, one of 2 things has to happen. Either I need to lose weight or I need to open the door. Okay? And this is usually, I'm saying this after there's been a course of medical therapy. Okay? Whether it be antibiotics, steroids, and we'll talk about this, nasal sprays, whatever it might be. And they may or not have gotten complete improvement from that. The medications, what I just treated you with, that was trying to lose weight. Okay? It didn't work. Didn't lose enough weight to get through that door. Now I got to open the door, right? I've got to change the structural things that are an impediment to great airflow. And airflow in the nose and in the sinuses, and I'm going to let you talk about gas exchange and that type of thing, why it's so important. But that's a big deal. Okay? So I open the door. If I open the door, now I can walk through no problem. Everything's great. Life is wonderful. But what if I start gaining weight again? If I start gaining weight again, I might start having trouble getting through the door. So that's where I've still got to treat the underlying allergy, even though I've made the structural change.
Yeah, a lot of people miss that because they're coming in with their mindset already kind of glommed onto one idea because they were told they had allergy or sinusitis, and they get confused between the two. The two interplay. There's a lot of interplay between stuffiness, drainage, face pressure, ear pressure, and the two entities that mostly cause it, allergies and chronic sinusitis. Remember, at any given time, if you're getting swollen inside your nose, you have the opportunity to have a combination of those things. We're trying to treat things that we can treat to take swelling down and structurally change the openings so we don't wind up revisiting that in 6 months.
So let's switch to...
We're trying to prevent the new one.
Yeah, so let's switch to treatment, okay? We've decided we have allergy, okay? Chronic sinusitis does not seem to be a big deal with this particular patient. I just need to treat allergy. How do I treat it? What are the... Start from the easy to the more complex, the things that may work this week but aren't going to work long term versus something that may even be curative.
I mean, that's a great question. People are always wondering that. Allergy is a billion-dollar industry. I mean, over-the-counter meds kind of rule. You can use steroids, you can use antihistamines, and quite often people do. Remember that a lot of the treatments that you have for it are designed to decrease the effects of that IgE we're talking about. You're trying to stop what's happening with your histamine release. Antihistamines are a mainstay. There's also other things like Singulair and long-term inflammation that we're trying to calm down. Steroids, topical, typically not oral, but topical steroid sprays, things like that. That all really helps. But you'll have to be on that the rest of your life. And so what we try to do is to try to teach the immune system to stop behaving that way. And that's where the drops under the tongue and the shots for 3 to 5 years really help. Because you're in a Th2 pathway and you're trying to switch. And what that means is that you're expressing the wrong proteins on the cells of your immune system. And we're trying to get that immune system to switch over to a Th1 pathway and express the appropriate proteins. And the way we do that is through antigen-presenting cells. What does that mean? The reason we use the skin is because it's kind of a historical artifact. Why do allergists all want to poke you for 3 years? They use the skin because at the time that they were doing this, they thought, again, hay fever was an illness and they could treat it the same way as vaccines. So it's kind of an artifact of the vaccination development that we use the skin. And there are antigen-presenting cells that you can present these things that you're allergic to. We just take, pollen and dander and dust, and we chop it up and put it in some liquid, and we inject it under the skin, and you present it to these cells, antigen-presenting cells, APCs, and you sort of say, hey, this is the stuff you're reacting to. Take that and calm yourself down. Make it less inflammatory. And the antigen-presenting cells that are under the tongue are actually better for that. Matt, that's why the behavior of children to put things in their mouth, they wind up developing strong immune systems with very little allergy. If you look at kids that don't get allergy, they're the kids with pica that eat dirt. I mean, the more that they're exposed to in their life, the less chance they have of reacting to it aberrantly. So really, it's kind of immunotherapy is a great way to get rid of this over time and cure it. So meds over the counter, you're going to have to use it the rest of your life and switch them up every year or two because you get used to them. But immunotherapy is a way that at least it's 3 to 5 years, but at least there's a cure out there where you may not need anything anymore, and we've fixed the problem.
So to your point about the pica, about eating dirt, we've really, when you think about it, created a whole generation of peanut allergy. in this country. And why is that? That's because the recommendation was not to allow your child, your baby, to have anything with peanut, to be exposed to peanut antigen for years. Well,
yeah, for fear of having that 1 in a million that
for fear of allergy.
Yeah.
Well, what country has virtually no peanut allergy? And the reason is because by 3 months old, every child is eating a little peanut treat.
Who's that?
Israel, right?
Israel,
so,
really?
Israel.
I wonder if Thailand's the same way, because they have that incredible peanut sauce, which I love.
Well, there you go. There you go. But yeah, they have a treat, and it kind of looks like what is that? It's kind of like a puff, and it's coated in peanut powder, and they give it to all the babies, and so they're exposed very, very early on, and they get virtually no peanut allergy because of it. Well, in this country, the mantra has been for a whole generation that you can't expose your baby to peanut. And look at all.
Well, we
the
also clean incessantly. I mean,
sorry?
you know, if we also clean incessantly, and typically, if baby drops the binky gets thrown out. Whereas, I mean, in a lot of places, like my wife's Filipino, and in the Philippines, that's unheard of. You just grab it and stick it back in their mouth.
Right. So the lack of exposure means the immune system's not getting a chance to develop.
Correct. That's right. Also, the overutilization of antibiotics, people have point to. So, you know, typically running to the doctor when you have a small fever as a child, and then they sort of half diagnose an ear infection and sort of throw some antibiotics at them. That's actually been implicated a little bit in the development of allergies in the first world.
So I want to touch back on just quickly on the medications that we were talking about. So antihistamines. First thing we have to know about antihistamines is they treat what are called early phase allergic reactions. Sneezing, watery itchy eyes, runny nose, postnasal drip. They do not treat nasal congestion. They don't treat facial pressure. Okay? Why? Because antihistamines only affect early phase allergic reactions. Late phase allergic reactions are things like swelling, okay, which cause nasal congestion and sinus pressure and that type of thing. That's why you have the Claritin D, Zyrtec D, Allegra D. The D is the decongestant. That's what treats that other side of the coin. So, people.
Do you think people overuse the decongestants, Lee?
Yeah, well, the problem with decongestants is, generally speaking, they can increase your heart rate, increase your blood pressure, and that can be a real
I think
problem.
They're pretty dangerous, actually.
Yeah. Well, look, now we have to give our license, right? Well, at least in Florida, we have to give our license just to get a decent decongestant. There are two decongestants out there. One works really well, the other one not so much. The one that works really well, you got to get it from behind the counter, and you got to show your license because people are using it to create recreational drugs. But the bottom line is we don't want people on long-term decongestants. So that's a real issue there.
If you're having to take the Allegra D, folks, if you're having to take the D of anything, you probably should be seen and try to figure out what's going on. Maybe there's a better way. Maybe there's a deviated septum, a structural thing. Maybe there's chronic sinusitis going on. You shouldn't be chronically using Afrin. You shouldn't chronically be using Sudafed or anything like that. Those are things that are a little bit dangerous to the body in when you use it long term. Better to come in and figure out what's going on and get it fixed permanently.
Yeah, and those topical decongestants like Afrin, Zicam has a topical decongestant, Dristan.
Yeah, oxymetazoline is the drug. If you see oxymetazoline, kind of a big word, but if you see oxymetazoline on something, that's a decongestant, and that's dangerous. That has cardiac effects and blood pressure effects that can be long lasting. Plus, it damages the inside of the nose, makes it harder for us to fix it when you do come in.
Yeah, you get a significant rebound effect. In other words, it works really well in the beginning, and then the lining of your nose wants more and more and more of it. I've had people come in taking Afrin nasal spray, 2 sprays in each nostril every hour for the last 12 years, and look in their nose and their septum's gone. It looks
Yeah,
like they've been using cocaine.
sometimes you can't fix it. You can. It says to use for 2 days, so pretty sure 12 years is not a good thing.
Probably not.
Who are you who are so wise in the ways of science?
So the next big drug that there's a little bit of a controversy with is Montelukast. Right, so these leukotriene receptor antagonists that I see tons of people,
and those are
on.
prescription. So the antihistamines you can get pretty much anywhere, but Montelukast you have to have a prescription for it for a reason, and that's for the long-term inflammation.
Right.
So we prescribe. People call it Singulair. There's other names for it. But those are the things that, in conjunction with the antihistamines, that we give sometimes in a comprehensive allergy profile. If somebody doesn't want to do immunotherapy, they want to do drugs going forward, that's going to be part of it, probably.
Now, the problem with Montelukast, first of all, from my perspective, I don't really feel that it works very well on allergic rhinitis for nasal symptoms as it relates to allergy. I think it works well in a certain subclass of patients that have asthma. That's allergic asthma. I think it can work well with that.
Yeah, that long-term inflammation of the small airways. Yeah,
right.
I agree.
But the big thing is it has a black box warning, and people might not know what a black box warning is. It's really more for physicians to look at, but a black box warning on a drug means that there's something very specific, usually
that comes from the FDA.
Yeah, usually a post-marketing issue. In other words, they didn't know about it when they first got the FDA approval, but afterwards, the people have been reporting this bad thing can happen if you use it. And the black box warning for Montelukast is that it can cause psychiatric issues, including suicidal ideation, if used over a long enough period of time. So I generally, if I have someone coming in with Montelukast being used for allergic rhinitis, I take them off immediately. I don't see it as being a great drug for that to begin with. And second of all, there's a black box warning, and I find that a lot of physicians out there don't even know that.
I think it's overused a little bit. I do. I try to use it only when I am dealing with somebody who's got a pretty severe airway issue, lung issue, lots of headaches. I've cleared up all the sinus problems, but they still get a lot of long-term inflammation, difficulty breathing. But yeah, if someone's just on it for a little runny nose, I get them off it as well.
So now, let's switch to chronic sinusitis. Treatment of chronic sinusitis. Now, we know there are surgical treatments for chronic sinusitis. We can talk about that at a later date. But medical treatment for chronic sinusitis, what's available? Is it curative? Or in chronic sinusitis, do you have to do something structural in order to make your way towards a curative solution?
Those are all great questions. Those are the questions we answer when you come in. And so it depends on the CT scan and the scope and my evaluation of you and my discussion with you. But, if you have structural issues that are blocking the way you breathe and blocking the outflow tracts, and there's a lot of things on CT scan, it's not worth getting into. There's a lot of things on CT scan we can see as docs that might be blocking the outflow tracts and making you a setup for chronic sinusitis. And we can correct those things. Not all of them are maximally invasive. Back when we started this, Lee, in the 90s, it was basically full-on surgery. And that surgery was open. Big cuts that we do, actually cut through the outside of the head and take the bone off and drill it down. But it's really changed quite a bit. And so we have a lot of big surgery that can be done just through the nostril, but also minimally invasive things. This is where the balloon comes in. This is where people start talking about balloon sinuplasty. We got the technology from the heart and blood vessels, but basically dilating these areas, the openings to these sinuses, that's what you were talking about when you gave your awesome analogy about how do you get things, meaning how do the sinuses get fluid in and out of them when they're swollen and they're closed. Well, when we usually either asleep or in a numbed state, we kind of put balloons into these openings and push them open. And because they're a little bone covered with mucosa, they act like safety glass, and you just kind of crunch them open like an eggshell, and they stay that way. And now they function a little bit better just with a simple balloon without cutting. So that's one of the ways that we help fix chronic sinusitis. Another way is obviously with medication. Medication is a great adjunct when you're doing surgical or semi-invasive procedures. There are cocktails that people talk about somewhere between topical and oral steroids and antibiotics working together to decrease inflammation and kill bacterial films. But in general, we start with medication and then go to the minimally invasive before we talk to people about what they call the FES, the functional endoscopic sinus surgery. So those are the mainstays of chronic sinusitis treatment. And the antibiotics, first-line therapy changes over time, but in general, it's put out by the CDC based on your area. And there are apps that docs look up where they can figure out what the resistances are in your area.
So kind of to put that in perspective, you've got allergy, which theoretically can be treated but not cured long-term with medications in certain individuals. Other individuals you can't. You have to go to immunotherapy to really get where you need to be. And then you've got chronic sinusitis, which might have an allergy component to it that you would treat as allergy itself, but also may have a structural component that if you don't correct the structural component, you're never going to completely get rid of the chronic sinusitis. And important.
Yeah, that's how they dovetail together. You're right. I mean, if you have structural problems, you got to fix them.
Right, 100%. And then importantly, there are minimally invasive techniques such as balloon sinuplasty, as you described, which you and I obviously are both experts in talking about this subject, that are very, very helpful in terms of even curing chronic sinusitis. Right. So probably if you're going to have one or the other, and you were the kind of person that said, look, I just want something to cure me, and that's the end of it, you might be better off having chronic sinusitis than having allergy, right? Even though many times you'll have both. So it's just very interesting the way these two go together.
Really important. That's a phenomenal point. That's actually putting your finger exactly on the problem that people come in with and some of the misunderstandings, because a lot of people come in with a preconceived notion about what's happening to them based on their own experiences and what they've read. And now everyone reads stuff now. Everyone's Googling. Everyone's in there looking at shows like this and trying to come in already diagnosing themselves. And if you have allergic rhinitis and you're coming in and you're convinced that it's allergic rhinitis because you've read, when we find evidence of chronic sinusitis, it's sometimes a little bit shocking to the person the course we want to take. But I always try to show folks exactly why I'm doing what I'm doing, and I present them with all the data, and I let them take all the data with them if they're not ready to hear it at that time. The harder one is when I fix someone structurally and I open their nose or I open their sinuses. You got to remember, they may not have been sneezing before. Their nose might have been so closed that they had very few allergic symptoms. So when I open their nose, I check everybody for allergy, even if they don't feel like they have it, because I've had probably 40 or 50% of people who I've fixed their nose, and in a month or two, suddenly they're sneezing and having drainage, whereas they weren't before, and they've come back and said, Doc, your surgery gave me allergies. Well, no, it uncovered them, and your symptom profile changed because the surface area inside your nose is 3 or 4 times what it was before the surgery.
Yeah, I call that the double-edged sword of expanding nasal airflow.
Right. That's exactly right. And patients coming in need to understand that. Just because sneezing doesn't always mean allergy. The absence of it doesn't mean that you don't have allergy also. The symptom profile can vary quite a bit, which is why it's so difficult for us as physicians to figure this out. So we're not magic. If you go in and there's a doc that you tell them what's wrong with you and they just give you something, they didn't do any tests. And they must be phenomenal doctors, because I need to do tests and get data in order to fix folks. I would be wary of folks that don't do any tests and just tell you what's wrong with you. Typically, I got to figure you out and it's not always that easy.
So here's our vital message of the day. The vital message of the day is, just because you don't have sneezing, watery eyes, runny nose, those types of classic allergy symptoms, does not mean you do not have allergy. Simply having nasal congestion, facial pressure, facial pain, headache, those types of symptoms alone can still indicate that you have allergy. So if you go to your doctor's office and your doctor says, look, we've got to rule out allergy, let the doctor rule out allergy. Okay?
And just because you have allergies
issue
doesn't mean that there isn't chronic sinusitis present.
Correct.
So I think that we've sort of established that there's definitely a combination of things that needs to be teased apart, and quite often they're happening at the same time. Let the doctor do the tests. Let the doctor get the data. And once the data is presented, let them lay out the treatment.
Fantastic stuff. Great podcast. I think we all learned a lot about chronic sinusitis and allergy, how to diagnose it, how to treat it. Great stuff. We want to thank you all for tuning into our podcast, and we want to invite you to keep tuning in. We have great shows coming up, great interactions, great discourse, great vital discourse. We'll see you next time.